All right, so we're halfway through physio. Fantastic, right? Everyone's, or is it more bittersweet? I understand. I get it. All good things must come to an end one day. But so we're starting with section 3. We're going to do the renal physiology. We'll see what we can get through. There's only 4 sections here, but renal and GI tend to take a little bit longer to get through. There's a lot of material there, so that's why there's not 5 different topics. So we'll do renal, digestive. We'll do kind of metabolism, some nutrition stuff there, and then reproductive systems. And again, that's when things get pretty awkward. Because again, I don't claim to know how women work in a lot of cases, and so that'll be glaringly obvious when we get to that section. Again, I have no idea why I'm still married at this point, but anyway, so we're going to discuss renal physiology. We're going to talk about regulation of fluids. We're going to talk about acid-base balance. We're talking about reabsorption, excretion, all these good things that go on within the kidney. Again, it's a very important topic. I'm not kidneying around. If you don't review this stuff thoroughly, you're in trouble come test time. Get it? Okay. Okay, so the functional unit we'll see of the kidneys is going to be what? A nephron. Yes, the nephron is very important. Have you covered any of this in anatomy yet? Okay, fantastic, good. So I won't belabor the anatomy stuff too much, but we'll kind of talk about how it's all kind of organized and how it's going to be important to our purposes here when we discuss the actual function of the urinary system. But anyway, so we'll talk a lot about the nephron. We'll talk a lot about where things are being reabsorbed. We'll talk about where things are being secreted. Because again, this system is very important to make sure everything is working in order, because we can regulate how our fluid status is for our patients. We can regulate electrolytes. How concentrated or dilute the urine is. This is all very, very important, because when things go awry within the kidneys, you're going to find lots of issues pop up systemically, right? So again, patients who have poor kidney function, you're going to find they can develop anemia, just like we talked about in the last section. They're going to have issues with fluid overload. They're going to have issues with electrolytes being thrown out of whack. So a lot of issues, and this is really important because a lot of stuff can lead to potentially your patient dying from these sequelae here. Anyway, and again, the nephron, it's important to understand kind of the anatomical kind of organization here and how things are kind of lined up with one another. So for instance, knowing that like the distal convoluted tubule is going to be approximated here with the macula densa, right? We're going to see that's really important for helping to regulate things like blood pressure, regulating things like renin release. And so we'll get into details on that, but kind of have a good understanding of how this thing is sort of organized here. And we'll go into more detail as we go forward. Now, talking just about the growth structure of the urinary system. Again, obviously, most people should have 2 kidneys, right? What sits on top of the kidneys? The adrenal glands, absolutely. We're going to have these ureters here. They're going to be kind of collecting all of the urine that's formed within the kidneys and then going down to the bladder. Of course, obviously, prostate is only going to be located in your male patients, and then through the urethra out to be eliminated from the body here, right? So obviously, there's some differences here. You'll cover that more in detail on anatomy for sure. However, to kind of get into the specifics of the kidneys, how things are working here, kind of notice how the nephron is going to be kind of located more towards the cortical side of the kidney. Notice how it's going to be kind of starting up top here. We'll look at how the blood flow is occurring within the kidneys in just a few minutes. But notice how the nephron is going to be located. You're going to find that, and typically the nephrons can have different lengths of basically how far down the kidney they're going to be projecting. And the longer they project down, the more kind of concentrating ability a lot of those nephrons actually have, which is good because it helps to regulate urine volume, helps to regulate just how concentrated the urine is going to be for us, how much we're reabsorbing or secreting, how much ever the case may be. But basically what you're going to find, you're going to start out with the renal cortex on the outside here. We're going to have the renal medulla, which you see here. And then located within, you're going to find these renal pyramids. Of course, they have sort of a pyramidal sort of shape there. But within the nephrons are going to be located. And you're going to see that they are going to have these collecting ducts on the nephrons. They're going to be kind of dumping out into these minor calyx, into the major calyx, finally to the renal pelvis, and then through the ureter. Okay, so that's kind of the general flow of things from the glomerulus down into basically the ureter. Again, looking at a radiograph of the urinary system here. I have animations here, but you can see how everything kind of dumps out into the bladder. We'll talk about bladder function in just a few minutes as well to make sure we know how that is regulated. How some of that is going to be involuntary, some of it's going to be voluntary. It's a good thing that some of it's voluntary, right? Because otherwise, what? You just pee your pants, and that's no good, right? Never have to go around wearing Depends all the time, and you don't want that to happen. So anyway, again, looking at the blood flow here, you can see, I think I have a better slide that shows you kind of all the details here. But again, a lot of blood flow heading through the kidneys. This is important because, again, kidneys are getting rid of a lot of waste products. We want to make sure that blood flow is maintained. We'll talk a lot about how we can regulate that blood flow, kind of what's being filtered at the glomerulus. We'll talk about filtration pressures and whatnot kind of coming down the road. But again, maintaining those pressures, make sure the pressures within the normal range is not too low, not too high, are going to be very, very important. And this is what a lot of our things like the renin-angiotensin system are going to be really important for that. So we'll talk about that ad nauseum a little bit later on in this section. Okay, so again, as I mentioned, urine is going to be made in the nephron, drains into those minor calyces, into the major calyces, the renal pelvis, the ureter, finally to the urinary bladder, and then finally out through the urethra, out of the body, right? Now, again, we mentioned some anatomical difference between male and females. What do you kind of notice about the urethra there? Typically longer in which male or female? Usually male patients, right? And that's good because that can help us to prevent things like UTIs. So normally think UTIs being sometimes more of an issue with female patients because they have a shorter distance there. Because again, you're located near the outside of the urethra, the rectum, and that's where a lot of bacteria live, right? So again, that's why you can find that shorter distance. You may find more issues with UTIs, especially in female patients. Also the prostate, and we know what the prostate is doing for us. Helps with certain secretions. We'll talk about that in the reproductive system later on, but it also has high zinc content. The secretions that the prostate has a lot of zinc, and zinc itself can be antibacterial. So we actually have an extra little defense system there to try to prevent things like UTIs. And actually, I just had a case on Monday of a young female patient. Actually, I had a 17-year-old female patient who developed a UTI, was started on antibiotics, did not respond well to it. So this is at an outside hospital. Ended up coming back, and she was in full sepsis. And what sepsis is? Basically full body-wide infection, inflammation, everything was going very poorly for her. Blood pressure was bottoming out. She was getting very acidotic. Her kidneys started to go into acute kidney failure. So we'll look at some of the things we look at when we see kidney function. But basically her potassium, normal potassium on the high end is like 5. Her potassium was 7. Very, very high. If you ever hear potassium is 7, your sphincter tone should kind of tighten up a little bit there. I'm really concerned about those patients. Her creatinine, we'll look at creatinine again a little bit later. Like usually maybe creatinine of 1 would be considered normal. Hers was like 5. Very, very poor kidney function due to her sepsis. Unfortunately, by the time she got to us, she ended up succumbing to her disease and died, unfortunately. But it's one of those things where even kind of routine things like UTI can actually go pretty wrong, especially in a younger patient. She might have had something else going on. We didn't get the full story. But again, just be aware of some of those anatomical differences like UTIs. You normally think female patients, right? Unless there's something else going on with the patient, like a indwelling catheter or something like that. But anywho. So, right, but once the urine gets transported, it's going to undergo peristalsis. What is peristalsis? Kind of synchronized muscle contractions that kind of force things down the tube, so to speak, and kind of force it along in one direction, essentially, right? Because again, we don't want to have a lot of backflow there. We don't have a lot of regurgitation because we need to get rid of all that urine because again, it's full of waste products. We don't want, anytime you have kind of stasis there, you run the risk of having bacteria start to develop. Because usually urine is pretty sterile for the most part. But sometimes when you have issues like that, peristalsis isn't working right, you can run the risk of infection and whatnot. Okay, so looking at both of the ureters are going to be dumping into the bladder, obviously. And so what's the big muscle that controls the bladder? Yeah, the detrusor muscle is going to be the big thing we're going to be focusing on as far as how we're going to be regulating that from both a sympathetic and a parasympathetic standpoint. Again, the autonomic nervous system is going to rear its ugly head again, as we'll see. You're going to find the ureter is going to dump into this trigone area right here, and then everything else is kind of surrounded by the detrusor muscle. So again, when you have contraction of the detrusor muscle, what do you think would occur? Probably, if it squeezes, it's going to force all that urine where? Out, right? It's going to force it out of the urethra, and then you should have urination. If you have relaxation of that muscle, guess what happens? You can store more urine, essentially, right? So again, that's going to be really important when we talk about what's going to be causing a squeeze of that muscle. It's going to be causing relaxation, especially when we're talking about the autonomic nervous system there. Just a few minutes. But again, it's going to be entering from the posterior aspect of the trigone area, and then once it's there, it's going to be kind of locked in the bladder. You don't want to, again, you don't have a lot of regurgitation there back up through the ureters, and so everything should be going in one direction essentially. We're also going to notice that coming out of the bladder, we're going to have both an internal and an external sphincter. Those are important to understand the function of those two as they are different. Which one do you think is under voluntary control? The external, and this is going to go when we talk about the digestive system and talking about the external and internal rectal sphincters, but basically the external one's always going to be under voluntary control up to a certain point. The internal one's always going to be under autonomic control, essentially, right? And which is good because we want to have some voluntary control of that because, again, what would happen? You pee your pants, right? And remember Billy Madison? The old lady's like, "A pee in your pants is cool, and I'm Miles Davis." Like, you don't want to be Miles Davis in this situation, right? Like, you want to make sure you have good control over your bladder. Anyway, I mentioned the trigone area. You're gonna have the internal sphincter, the external sphincter. This one's going to be under voluntary control. Again, that's up to a certain point. Again, there's only so much contraction you can have there. But we'll talk about the nervous system integration there and how that's going to be working. But again, basically the detrusor muscle, the internal and external sphincters, that's what's going to help to regulate just how much urine we can store in when we actually want to cause micturition or urination. That's when that can occur. Okay, and back to the kidney itself, we're going to have two main areas, the cortex and then the actual medulla. Again, this is where we're going to have a lot of those nephrons kind of projecting down. This is where a lot of the concentration, the actual urine is formed here as they're going to be dumping out into the eventually the renal pelvis and then can be excreted out through the ureters. Okay, so getting into the actual nephron itself, so you kind of notice here, here's two examples of two different types of nephrons. Here's one's going to be considered a cortical nephron. Notice here it's mostly located where? In the cortex, right? So you're going to find that this is going to have some ability it's going to be able to produce urine. You're going to find it's not really going to have as good of a concentrating effect as you're going to see with these kind of longer juxtamedullary sort of nephrons here. So then these are going to be much better for concentrating. We'll look at why that is, and a lot of it has to go with the distance that is able to project down into that renal pyramid a little bit later on. And what do you notice about the blood flow here? It's tightly integrated with the nephron itself. So we're going to find that this is called the vasa recta, which are basically this network of capillaries that are located right next to the nephron, especially when we're talking about things like the loop of Henle here and a little bit later. You're going to realize that that's really important because this is going to allow us to have flow of both water potentially and also electrolytes. Okay, this is what's going to give us the ability, say for instance, we secrete a bunch of, or we filter a bunch of sodium out of the glomerula. It's like, well, how do we get that sodium back? And that's important because we want to make sure we get it back into the bloodstream. Because again, all the urine that gets filtered through the kidneys doesn't get just eliminated in the urine. You want to hold on to a lot of that. And so we'll look at that a little bit later on. But just know that integration there with the vasa recta is very, very important for helping to make sure we reabsorb things or excrete things as needed here. Okay. Okay. Renal function specifically, what are the job of our kidneys essentially? So get rid of waste products, right? So things like urea, which you get from breakdown of amino acids. Things like creatinine. Where does creatinine come from? Right, it gets broken down from creatine found in the muscles there. Good. Things like uric acid. So again, when you have breakdown of things like purines, nucleic acids, things like that will end up producing uric acid we need to get rid of. We'll also find that sometimes bilirubin, a little bit of bilirubin will be excreted through the renal system. But also a lot of things like toxins, food additives, different products can be eliminated through the kidneys as well. Especially in farm, when we talk about that, kidneys are a huge place for drug excretion to get rid of those. Otherwise, if you hold on to them too long, you can potentially have toxicity that develops there. So again, getting rid of waste products is one of the big functions there. If you have this go right, obviously you're going to build up with these products, which can lead to all kinds of issues, as we'll see. On the other side of this, you're going to have regulation of water and electrolyte balances. So again, if we have too much water in the system, that does what to your urination? Say we're drinking an entire gallon of water. We're going to stimulate urination, right? So at the break, you're probably going to have to go to the bathroom, if I had to guess. Not to call you out, but just saying, if you're drinking a gallon of water. Also, things like, if we have dehydration, typically what happens to your urine production? Typically goes down, right? So you're not going to have to go to the bathroom quite as much. This is also going to be useful for helping to regulate electrolytes. So things like sodium, chloride, potassium, calcium, all of this is regulated through the kidneys as far as excretion or reabsorption goes. So again, if you have someone who has really poor kidney function, guess what? All those electrolytes are tend to build up in a lot of cases. And you run into issues where hyperkalemia can be a potentially life-threatening complication of kidney dysfunction. And frequently, I mentioned, what do we put patients on when their kidneys stop functioning altogether? Put them on dialysis, right? So typically patients would go on, say, intermittent dialysis, which means they will get it, most commonly they do it like Monday, Wednesday, Friday, go for 4 hours, hook them up to the dialysis machine, filter out the blood, put it back into them, and then they're good to go for a couple of days, right? Oftentimes what you'd see in the ERs, especially like a Sunday, Monday morning or something like that, is you'd have patients who had skipped their Friday dialysis. So again, they basically had dialysis on Wednesday, maybe they got too busy or something on Friday, skipped it, and then went for that extra couple of days without having any kind of filtration of the blood. And then they come in, their potassium again's like 6 or 7, the creatinine is sky high, like they need emergent dialysis at that point. So again, you don't have good regulation of electrolytes, it can be potentially life-threatening, as I mentioned. Okay, we're also going to help to regulate things like blood osmolality, right? So again, this is where things like antidiuretic hormone are going to be working here. We'll look at specific parts of the kidney where this will actually work. Again, we can help to regulate things like water and salt reabsorption, especially antidiuretic hormone mainly focused on water reabsorption, but things like aldosterone. Remember what aldosterone did? That was water and salt reabsorption, but at the cost of what electrolyte? Yeah, potassium was what gets wasted in that case. So again, we'll look at some different places in the kidney and how those are actually working specifically. But again, this is where you're going to have regulation of blood pressure as well. So again, if the kidney detects there's not enough blood flow, it's going to start to activate some systems there to try to hold on either to more water, right? Or it's going to be activating things to try to increase the blood pressure. Because again, the kidneys, they require a lot of oxygen, they require a lot of blood flow. And so they're going to help to make sure they can maintain that pressure as best they can. Because again, if you don't have the pressure there, no filtration actually happens. And so that's when the renin, angiotensin, aldosterone system is going to get activated. We're going to talk about that again a little bit later on. But remember, what was the main purpose of the renin angiotensin system? Increase blood pressure, right? Because again, the kidneys need that pressure there to make sure that GFR, that glomerular filtration actually occurs. If they don't have that, then nothing gets filtered, and then guess what? You're going to have some issues there, okay? So again, we'll look at some of the negative feedback loops that happen when you're going to integrate these systems here to help regulate that blood pressure. Again, we talk about antihypertensives when we get to Pharm 1. Guess what? This is going to be a huge system. One of the huge targets we're going to be focusing on to actually help fix patients' hypertension issues. Okay. The other functions of the kidneys include things like regulation of acid-base balances, right? So again, we can excrete acids if we need to. We can excrete bases if we need to, mainly the main base being sodium bicarb. And again, this is one of those things where if you have dysregulation of the kidneys, you're going to have issues. We're going to have, usually the patients tend to become more acidotic because they can't get rid of a lot of these acids and things, especially from muscle breakdown. So because of that, they tend to become very acidotic. They get very, very sick as a result of that. And then the last thing here is the regulation of erythrocyte production. We talked about that already. Again, erythropoietin being the main hormone that gets stimulated from the kidneys when they detect there's not enough oxygen being delivered there to the kidney, right? Again, going back to that one test question where it was like, okay, well, which one of these patients wouldn't be able to mount wouldn't be able to produce enough erythropoietin? What was the patient that wasn't able to do that? The dialysis patient, right? Someone who had non-functioning kidneys, essentially, right? So you can have patients who have, say, poor iron intake, but maybe they're still able to produce a ton of erythropoietin. They're still anemic, but their issue is iron intake. It's not they can't produce enough erythropoietin, right? So again, that was kind of what that question was trying to get at. But anyway, so again, that's another main function of the kidneys here. And again, big problem with a lot of chronic kidney disease patients is going to be anemia, either due to blood loss due to their intermittent dialysis or the fact they don't have enough EPO that are making themselves, right? Okay, we'll see that the renal system is also going to be useful with certain hormones. So for instance, vitamin D actually gets activated within the kidneys. There's kind of a two-step process for vitamin D activation. Normally, and where do you get vitamin D from? Either sunlight, right? So I mentioned if I did a study, I'd probably find guys on this side of the room are going to have a little bit better vitamin D production maybe than people on the other side, perhaps. Who knows? That's one place. Where else do you get it? Yeah, your diet, right? So again, diet and sunlight. So that's not actually the activated form. Your body still has to actually change that. And there's two places that happens. One's in the liver, where they have basically there's a first hydroxylation step, you had a hydroxyl group, and then there's a second hydroxylation that occurs down in the kidneys. So this is another thing where patients have poor kidney function. Oftentimes they don't have good vitamin D levels, or they don't have a good active form of vitamin D that they can produce, and they have issues with things like osteoporosis. They have issues with absorbing calcium from the diet, all kinds of problems, right? So again, the activated form here is just 125-dihydroxyvitamin D. Another name for this is called calcitriol. So sometimes what we have to do for kidney patients is actually give them the already activated form. It's a lot more expensive than just giving them stuff in their diet or sending them out in the sunlight for a while. But it is something we have to do because we know that their kidneys can't actually produce the active form themselves. Okay. And then there's a limited amount of gluconeogenesis that occurs here, but not like you would see with like the liver necessarily. But if you're in a prolonged fasting state, you can get a little bit of glucose production coming from the kidneys. Okay, so as I mentioned, mainly what we're doing here with the kidney function is having to regulate a lot of the extracellular fluid environment in the body. So a big thing here is regulating the blood plasma volume, right, which is going to directly affect blood pressure. So again, if I have a lot of excess urination, what do you think that does to blood volume? Should decrease it, right? So again, you can see hypotension as a result of that, right? So for instance, if someone's like abusing diuretics to cut weight or something like that, they have an eating disorder, you get someone who has very depleted intravascular volume because they're urinating all that volume out, right? So that's one big thing the kidneys help to help with. I mentioned the waste, electrolytes, and also the pH. So these are the big cases where patients need kidney function. Otherwise, these all go awry if they do not have good functioning kidneys. And they're usually going to be the cases where dialysis is actually indicated. So for instance, if someone's like really acidotic, I can hook them up to an artificial kidney and can filter out all those acids essentially if their kidneys can't do it themselves, right? Or if their electrolytes, I can get rid of extra potassium and things like that potentially. So again, all very important functions. Okay, so let's talk about micturition, which is otherwise known as urine. Good. All right, so how do we actually control micturition itself? You're going to find there's several nerves are going to be involved here. Most of this is going to be involuntary. Some of it can be voluntary, as we're going to see here. So for instance, every time you sneeze or say cough or something like that, do you pee a little bit? Typically no, right? Because you have things like the guarding reflex that actually help to prevent this, right? You have things like voluntary control of some of these muscles that helps prevent that from occurring. Now, there's some people that do have that issue, yeah, especially if they have like anatomical changes that occur. So, for instance, after, say, for instance, giving vaginal delivery of a child, sometimes you can have some changes that occur their urethra. So that's a common complaint with some women after giving birth is they, have an impaired guarding reflex. But basically, what you're going to find is there's going to be a lot of stretch receptors that are going to be located within the detrusor muscle here, right? And stretch receptors are going to typically respond to what? What might stretch out the detrusor muscle? Yeah, urine is right. So as we produce urine in the kidneys, it's going to be dumping out into the bladder, and as you get more bladder volume, that's going to be stretching out those receptors, right? But typically, what you're going to find is that when those stretches occur, what do you think the muscle wants to do as a result of that? Actually, going to want to relax somewhat, right? Because again, you don't want to just have one static volume of urine and then you have to go to the bathroom, right? You want to be able to hold on to it more if you need to. So typically what you're going to find is as you stretch out those receptors in the bladder, that's going to cause some muscle relaxation. This is up to a certain point though, right? Because again, your bladder is not an infinite storage vessel, right? At some point, you're going to have to go to the bathroom. So you're going to find that there's going to be some receptors here. They're going to be traveling up into the pons here, where you have this pontine micturition center, right? Again, here's the nerves that are going to be kind of sensing that essentially. You're also going to notice there are going to be some sympathetic nerves. They're going to be innervating the detrusor muscle. You're also going to find there's some sympathetic nerves that are going to actually be innervating this urethral sphincter as well. And then you're also going to have the parasympathetic nervous system going to be innervating the detrusor muscles as well. So if you had to guess with the parasympathetic nervous system, what do you think that would do to urination? Increase it, decrease it? Typically increases it, right? So again, if you think about the parasympathetic nervous system, you want to think causing you to secrete fluids from everywhere, essentially, and that includes the bladder as well, right? Did I ever tell you the mnemonic I use to remember the parasympathetic nervous system, the effects of it? Okay, here's a good mnemonic. It's going to help you out with remembering some of the effects of the parasympathetic nervous system, right? It's called dumbbells with 3 B's. Okay, you ready for this one? The D, anyone know what the D stands for? Defecation, right? So again, it stimulates the GI tract to cause defecation, right? U, urination, right? So we can imagine the parasympathetic nervous system is going to stimulate urination. Good. You know what the M is? What does the parasympathetic system do to the eyes? Cause meiosis, yeah. So we're going to find meiosis is the M. And then we have what I call the killer B's. These are things that are going to cause potentially death for your patients if they have an overactive parasympathetic nervous system. But it's going to, what does the parasympathetic system do to the heart? Bradycardia, good. What does it do to the lungs, you think?
Constriction.
Bronchoconstriction, yeah, it doesn't cause bronchodilation, right? Because we talked about the sympathetic being good for bronchodilation, but it causes bronchoconstriction. Also, what does it think it does to the fluids in the lungs? So if it stimulates urination, it stimulates defecation, what do you think it does to the lungs? Stimulates secretions, right? So again, you can find bronchorrhea that occurs there, right? So you're going to have a lot of bronchial secretions that actually develop. And again, the patient's lungs are filled up with all this mucus and fluid, and they're bronchoconstricted. Guess what? They're not going to oxygenate very well. That's what potentially can kill a patient if they had, say, for instance, something that caused their parasympathetic nervous system to be overactive, right? There's certain toxins that can do that. Anywho, so those are the 3 B's, okay? The E, anyone know what E stands for? So it's coming out one end of the GI tract, comes out the other end. M is this, good. And L, lacrimation, good. And then S? Salivation, yeah, good. So again, lacrimation, they'll be crying. Salivation, they'll be drooling excessively. So again, the parasympathetic nervous system causes a lot of secretions to occur. If your patient's basically oozing out everywhere, if you have an overactive system, and there's certain pesticides that can actually do that. But so the thing to remember here is that when you have parasympathetic activation of the detrusor muscle, it's going to cause what? You think a relaxation or a squeeze? Actually going to cause squeeze in these cases because you want to stimulate urination. So it's actually going to cause squeezing, and we think it is going to do to the internal urethral sphincter. It's going to cause it to relax. So in this case, it's going to cause constriction of the detrusor muscle, but relaxation of the internal sphincter. Make sense? That way it's going to be stimulating urination in those cases. Now on the flip side of that, say for instance I had the sympathetic nervous system going, say I had an alligator leap out at me. Actually I had a soft shell turtle who got caught in the area by my house. And so I was trying to dig a hole for him so he could get out under the fence and get back to the lake that's nearby. And he actually jumped at me. And for a second, I was very scared. And so I had my sympathetic nervous system. I wasn't expecting him to move quite so quickly. He's a turtle. I was like, he's slow, but he was not so slow. So in that case, what do you think was happening to my bladder at that moment? The sympathetic activation. You think constriction of the detrusor or relaxation? In that case, it's actually going to be relaxation because, again, you're in a state where you don't necessarily need to urinate. You need to hold on to that potentially because, again, if I hold on to more urine, what is that going to do to my blood volume overall? It's going to increase it because, again, we're going to have backup through the kidneys, and they're going to say, hey, I don't need to be producing as much urine here. Let's hold on to that volume because, again, you want blood pressure to be up. You want to be able to supply the muscles, all that nice oxygen-rich blood and whatnot. So you can see how the sympathetic nervous system will cause relaxation of the detrusor muscle. You think it would do what to the internal urethral sphincter? It would be constrictive, right? So again, because I want to make sure that I'm pinching that off, make sure I'm able to hold on to as much urine as I can in those cases there. So you see how they have, again, antagonistic actions to one another between parasympathetic to sympathetic. Yes, ma'am?
So if parasympathetic wants to urinate and sympathetic prevents it, what is the correlation as far as you're so scared you refuse?
That could be a case, and I was thinking about that too, because you think oh man, I got so scared of people. I didn't do that with the turtle, but it wasn't that scary. It wasn't like a big snapping turtle or something. But that could just be a case where potentially you just have some dysregulation that occurs there. Maybe the muscles relax themselves or something, or maybe you're just so thinking about, I got to get away from this thing, that maybe you loosen that voluntary control. Because again, the external sphincter is always under your control to a certain point, right? So again, there's at some point there's enough pressure, there's enough reflexes there that cause you to urinate regardless, right? So again, because you can't hold that infinitely. But maybe there's some issue with the external urethral sphincter that may loosen up and then allow so for some urination to come out, or some urine to form there. So that's my best guess. But again, you may be able to find something in the literature that says something different, maybe something smarter than what I said. Do you have a question?
I don't know. I've heard that at the moment you don't feel yourself, but as soon as it goes by, that's when
Yes, may have a little bit of a reflex there because again, having that big squeeze may cause some reflexes there. May want to try to balance itself out by having a little bit of that urination that occurs there. So, anyway. All right, so this is important because, again, we want to make sure we have good control of this, especially when you're looking at drugs like certain side effects. You may find that urinary retention may be an issue. Maybe excess urination could be a problem depending on the type of things you're dealing with. So we'll get into the specific receptors in a little bit. That's the general function of the autonomic system, looking at urine control. And again, you're going to have this pudendal nerve is going to be coming and sending kind of these efferent signals here. They're going to be mainly controlling the external urethral sphincter that will allow us to have voluntary control of that. So if I wanted to say my bladder is telling me I need to go to the bathroom, but I'm saying I'm in the middle of a lecture, I can't go right now, I can still hold on to that and make sure I can exercise that voluntary control and not go to the bathroom in front of all you guys, because that would be pretty embarrassing. Never again, I say. Okay. So again, looking at these reflexes that occur, I think this is a little bit better picture where you're kind of looking at both kind of voluntary control versus the parasympathetic and the sympathetic control here. But basically what you're going to find is, if you imagine looking at this graph here where you're looking at the intravesicular pressure here, the intravesical pressure. So again, pressure as far as centimeters of water, how they're measuring it here. And look at the volume of the bladder itself. What do you kind of notice about these contractions that occur here? And so they're getting... They don't really go that much quicker, but you notice the amplitude of contractions actually gets a little bit stronger. So basically what you end up having is, with the bladder, it gets a little bit stretched out. You're going to have kind of a reflex sort of contraction a little bit, but then it relaxes. It contracts a little bit and then relaxes. And so again, when you have those cases where it's like, man, I really have to go to the bathroom, and all of a sudden like, man, I hold it long enough and now I don't have that same urge to go again, right? That's one of these kind of contractions kind of wavering there. And so again, because you want to be able to allow that bladder muscle to relax, to fill up to a certain degree before you actually have to go to the bathroom, right? So again, if you had issues to where maybe that muscle could not relax enough, what do you think it's going to cause for the patient? You're going to have urinary frequency, right? So if I couldn't relax that muscle well enough, I'm going to have that kind of urge to go to the bathroom all the time, because again, very small volumes in the bladder may be able to trigger off that reflex. Hey, I really need to go to the restroom right now, right? So again, you're going to have these micturition contractions that again get more strong in their amplitude as the bladder volume gets bigger and bigger, and that's what's going to be stimulating you to actually need to go to the restroom. But again, we always have that voluntary control in the external sphincter that helps us to kind of prevent that, right? And again, looking at things like this, when you're looking at like inhibition of the sympathetic nervous system, that's what's going to cause the internal urethral sphincter to actually relax or open. So again, it's not just stimulation, but it's also having diminishing the effects of either sympathetic or parasympathetic, can have the opposite effects as well, right? So in this case, if I need to go to the restroom, I can relax that sympathetic outflow, decrease that, and that should open up that internal urethral sphincter and allow for urination to occur, right? So again, it's always going to be kind of a balance between the two. I mentioned parasympathetic nerves are going to be causing the detrusor muscle to contract. Typically, this is going to be mediated through acetylcholine, as we mentioned, but it's going to be on these muscarinic receptors. Again, I'm not going to ask you specifically which muscarinic receptors. Just know that they are muscarinic. They are affected by acetylcholine. That causes the detrusor muscle to contract in these cases, right? It's going to stimulate urination. Again, parasympathetic neurons, normally you're going to think voiding. Again, looking at here, you can see, I kind of like this picture because it gives you a good example of what's going on. So imagine here you have the parasympathetic nerve here in green. It's going to be releasing acetylcholine onto these muscarinic receptors. You expect to see contraction happen. The sympathetic nerve you're going to find is going to be better for innervating, especially that internal urethral sphincter. So again, you're going to be releasing what neurotransmitter? And remember? Typically, norepi is going to be the big neurotransmitter coming from the sympathetic nerves. But here you're going to notice it's activating a beta-3 receptor in the bladder, which you think, okay, well, beta-3, normally what does beta receptors do as far as smooth muscle? Usually relaxes it, which makes sense here because they're actually having a beta-3 receptor that's mediated by norepinephrine. It's actually going to cause bladder relaxation, so I can store more urine. However, on the other side here, you're going to notice there's an alpha-1 receptor. And we said alpha-1 typically does what to smooth muscle? Constricts it. So that kind of makes sense where both norepi, even though they're acting different receptors, you're having kind of synergistic actions here. I'm having relaxation of the bladder, but I'm also having squeeze of the internal urethral sphincter. Okay. So it's good for that to occur in concert because that allows us for storing urine appropriately. It doesn't cause, you wouldn't want both of these squeezing at the same time because that can cause issues, maybe overflow, incontinence, and things like that, right? And again, here's that pudendal nerve. That's that somatic nerve that's going to be under our control. Again, notice here we're talking about muscle activation later on in the class, but basically acetylcholine is working on nicotinic receptors here. That's kind of the big difference between the parasympathetic to actual like somatic control of nerves is that these are releasing acetylcholine, but it's on nicotinic receptors, right? Okay, so again, person when they're feeling the need to urinate, they can definitely control again when that external sphincter relaxes or constricts, as the case may be. And again, it's all going to be mediated through acetylcholine on those nicotinic receptors there. Again, it's through the pudendal nerve. Okay. Again, internal urethral sphincter is smooth muscles under involuntary control. Again, mainly parasympathetic innervation. It's going to allow for relaxation, dilation, opening. The external urethral sphincter is going to be more mediated through skeletal muscle. That's under voluntary control. We control that. And again, through the pudendal nerve. This will be important as well when we're talking about things like erections and whatnot later on, but pudendal nerve will come back up later. Okay. Any questions on urination? Ever need a bathroom break? We'll go in a few minutes. So again, exercise your pudendal nerve, exercise your external urethral sphincter, keep it constricted for another few minutes, and we'll have a bathroom break. Anyway, structure, looking at the actual blood flow itself. So again, where do we have blood flow coming into the kidneys from? So we're going to have some renal arteries, so these are going to be feeding into the kidneys, again, coming here through the renal pelvis, essentially. You're going to notice how they're going to be kind of breaking down into, a series of smaller and smaller vessels until we actually get to where the glomerulus actually lies here. So again, looking at the blood flow coming in, you're going to find that the renal artery is going to feed into these interlobar arteries. You can kind of see how it'll kind of break up and go to the different lobes of the kidney here. Then they're going to go into these arcuate arteries, then interlobular. So again, different from interlobar. It's interlobular. You can see where the interlobular are actually going to be locating here. Again, this is actually the good site to look at because this is where the actual glomerulus is going to be, the actual nephron is going to be located. Then the big ones I want you to focus on are going to be these afferent arterioles. Then you have the glomerulus, and what happens at the glomerulus? This is where the actual filtration, this is where all the business actually happens as far as getting that blood that is full of waste products and getting rid of some of those, right? So again, the glomerulus is where all the filtration happens. Then you have the efferent arterioles. So again, these three I'm going to focus on the most as far as being able to control how much filtration occurs by changing pressures, by either dilating or constricting these vessels, allows us to change how much filtration actually happens at the glomerulus. Okay, this will become really important later on, especially when we get to pharm, we're talking about different side effects that occur with these medications. You'll realize there's certain drugs that cause acute kidney injury or acute kidney decreases in function. A lot of it is mediated through these different vessels here, right? After that, at this point now we have more on the venous side of things. We're going to have these efferent arterioles are going to feed into the paratubular capillaries, interlobular veins, the arcuate veins, interlobar veins, and then finally out to the renal vein. At that point, it dumps out into the inferior vena cava, where it can then travel back up to the heart, right, to start the whole cycle over again. Anyone know a good way to remember afferent versus efferent? Which one's heading in, which one's heading away? Afferent is arriving or leaving? So the way I think about it, and this has helped me to remember it for all these years now, is you guys remember like Alka-Seltzer? Those tablets like you put in your water and the effervesces, cause all the bubbles to flow out. I think effervesces, leaving. So efferent arterioles are leaving the glomerulus. Afferent is heading into the glomerulus. That's important to remember because they have different hormonal effects. You may find that angiotensin 2 works on one versus the other, and that can affect blood flow to the kidney and affect filtration quite significantly versus things like prostaglandins are going to work on the other side of things. So we'll look at those details a little bit later on. But just remember the efferent arterioles are things that are going to be leaving the glomerulus here, okay? The afferent arterioles are what's coming into and carrying the oxygen-rich blood, okay? So effervescence, leaving, that's how I think about it. Again, my analogies probably don't work for anyone, but that's okay. All right. So you notice here's the arcuate artery and the arcuate vein. Notice here the blood flow is going to be traveling through here. We're going to have the afferent arteriole, right, heading into the glomerulus. This is where actually all the filtration occurs. Then you're going to have the efferent arteriole travels out of the glomerulus, and then this is where the vasa recta actually gets formed here. So notice how there's a very deep integration between the proximal and the distal convoluted tubules, the loop of Henle, how all these get integrated with one another. So that allows for free flow of certain things depending on where the receptors are located, depending on where water needs to go. It allows for flow there to occur. And then eventually they're going to all dump back out into the arcuate vein, which can eventually lead out to the inferior vena cava. Okay. Okay. So again, vasa recta is just those specialized blood vessels. Specifically, we're talking about the loop of Henle. This is going to be the most important one. He doesn't like Don Henley from the Eagles. I don't know if he was the one that actually found these in the first place. No Eagles fans? Okay. Because sometimes the place feels like the Hotel California. You know, you want to check out, but you can't ever leave for 2 years. Anyway. All right. But anyway, again, just another picture kind of showing you how the paratubular capillaries, this vasa recta is going to be deeply integrated here. This is going to allow for a lot of flow of water and electrolytes where, and again, different areas are going to have different flows, as we'll see, based on where receptors are located, where different channels are located to allow us to control just how concentrated the urine is going to be, how dilute it's going to be, if we want to reabsorb certain things, excrete certain things, it's all very important there. Okay, so again, the nephron functional unit of the kidney here, it's going to be, each kidney has more than 1 million nephrons, so quite a few of those are going to be there. Some of them are going to be more cortical nephrons, some of them are going to be more juxtamedullary nephrons, where again, they're going to be projecting further down into the medulla of the actual kidney itself. Again, the blood, this is where the actual filtration is going to be occurring here, right? So again, it's going to be entering through these tubules. It's going to modify and then leave the tubules as urine, as we'll see. Okay, so again, we'll have initial filtrate, and by the end of it, when it finally all gets into this collecting duct, again, which will eventually end up in the renal pelvis and eventually go out to the ureters, this is where we're actually having the actual urine being formed here. Okay, and you can kind of see how the nephrons are kind of located here. So imagine here's one of these renal pyramids, kind of starting at the top, but they're going to be having the afferent arterioles feeding blood into them, and then they can have their, we'll see all the journey that occurs throughout the nephron to actually produce urine at the very end, and then eventually all dump out these collecting ducts into, say, these minor calyces into the major, and then finally to the renal pelvis. Okay, let's see. All right, so starting out, we're going to have the glomerulus here. So I always have a Bowman's capsule. The glomerular capsule here is going to be surrounding the glomerulus. It's going to be the first step we're going to have here. And again, the filtrate is what's actually being produced here. Okay. So filtrate gets produced in that renal corpuscle, and this whole kind of unit right here. It's going to be dumping into the proximal convoluted tubule. So it's going to be the first step. Once we have everything filtered out of the blood, we're going to be hitting the proximal convoluted tubule. We're going to see we're going to go through each of the individual cells in each part of the nephron to see what's actually occurring at each of them. But again, this is the general flow of things. Basically, and again, this is kind of a more stretched out sort of form of the nephron versus more kind of the anatomically correct sort of orientation here, which you'll see. But anyway, so you're going to notice it's going to go to the proximal convoluted tubule, the PCT first. Then it's going to go through the loop of Henle. Notice there's going to be a descending loop, and there's going to be an ascending loop. Notice here that it has a thin portion on the descending part here, and then on the ascending portion, you're going to notice there's a thick loop of Henle. This is going to function differently than you're going to see with the thin loop. Okay, so again, just take a note of that. The thick loop of Henle is going to act differently than the thin descending loop. Okay. From there, it's going to pass into this distal convoluted tubule, and then finally it's going to go into the collecting ducts, and then finally heading out as urine into the renal pelvis, into the ureters, and be excreted as urine, right? So again, it's important to know these steps because again, at least for my purposes, especially when you get into like to the pharmacology side of things, you're going to find the diuretics actually work at different portions here. And we'll talk about that briefly, but just knowing where the diuretics are working is important because that kind of tells you, okay, what kind of electrolyte disturbances can I expect from this? What kind of issues can I expect to happen downstream of using these diuretics to change how the kidneys are actually functioning specifically? So again, this is the general flow of things. Bone's capsule with the proximal convoluted tubule. It's going to go through the descending loop of Henle, go through the ascending loop with the thin segment, and then finally the thick segment, the distal convoluted tubule, and then finally the collecting duct. Okay. Let's go ahead. We'll just do a 10-minute break now. We'll come back 10:56 and then continue on my GFR. All right. I'll allow the stragglers to come in on their own accord. Unless there's a song you want them all to sing. What do you think? Oh, she's turning around. She's like, no way. I'm not coming. Understandable. Any questions from the first half? All right. So continuing on. So we're talking about glomerular filtration. My words are already escaping me, so this is going to be a fun couple hours here. Anyway, so the term filtration is just basically everything getting filtered out through the glomerulus, right? So again, if you're looking at it from these pictures, you can see all the blood coming in through the afferent arteriole, leaving through the efferent arteriole. You're going to see that whatever's coming out through the glomerulus is actually going to be the filtrate, okay? Getting filtered. Reabsorption would mean what, do you think? It's being taken back up from the filtrate, and so again, these paratubular capillaries are where that reabsorption actually occurs, right? So you're going to find that we filter a lot of things that does not get secreted out into the urine itself. So for instance, like a lot of glucose. How sweet should your urine be? I don't recommend tasting. Typically not very, right? So again, you're going to find that there's always limits to how much we can actually filter and reabsorb, but typically we don't usually have a lot of glucose escaping in the urine, right? Unless you have an issue like diabetes, type 2 diabetes specifically, or sometimes type 1 depending on how well controlled they are. But basically, you're going to find that that reabsorption that occurs there, and it's through those paratubular capillaries. And we'll look at some of the actual cells themselves, look at the different transporters to see how that actually functions. Secretion is just where things that may have not been filtered in the first place are actually going to be secreted from the paratubular capillaries into the filtrate. Okay, so you may have some things that even though they are going through the glomerulus, they don't get filtered very well, but they may be secreted more specifically in there. So they can still get out through the urine, it just may not be at the glomerulus that actually is occurring, right? So that's going to be secretion. And then excretion is basically anything that makes it out through the urine, okay? So again, you're going to have some things that get filtered very extensively, but then get reabsorbed almost extensively. You're going to have some things that are not going to be filtered, but then get secreted, and everything in between. Okay, it just depends on the substance we're actually talking about. Again, this could be amino acids, it could be glucose, it could be drugs, it could be anything when it comes to the kidney function, as we're going to see here. Okay. Right. So looking at the glomerular corpuscle here, we're going to find that the actual capillaries are going to be fenestrated. Anyone know what the term fenestrated means? Got a bunch of like holes in it, essentially, right? So it's going to be very leaky. It's going to allow for things to flow through. Again, does it let everything flow through? No. Like for instance, red blood cells. Typically, don't want red blood cells. They're going to be too big to actually get through those fenestrations, and so they're going to be able to go through the glomerulus and head right back out, right? So again, that makes sense because typically you don't want a lot of your blood in your urine, right? You can't imagine a situation where you actually do. Again, you're going to find that plasma, a lot of the stuff that's actually dissolved within the plasma will get filtered. But again, certain things are not going to be able to go through. So for instance, things like large plasma proteins, typically those proteins are negatively charged. They're going to have a hard time getting through because they actually get repelled off of the lining there. So you're going to find that like big proteins don't go through. And typically, do you want to find a lot of protein in your urine? Not typically, right? So again, unless you have kidney dysfunction, that's when you typically will see that. You don't want a lot of proteins spilling out into the urine. And usually they're not able to even be filtered in the first place, which is usually good, okay? And then again, whatever gets filtered out is going to be considered to be our filtrate. And so looking at the molecular weight of things, and again, typically the larger the molecule, the harder a time it's going to have crossing those fenestrations. And so there goes its filterability. So for instance, water, pretty small molecule, can get across no problem, right? So again, 100% of that water can be filtered out, no issues. Sodium, very small molecule, can be filtered out, no problems. Have you started getting things like myoglobin? Where does myoglobin come from? the muscles, right? So again, that can be an issue where you're going to find that it typically does not get filtered very well, because again, it's a much larger molecule from a size standpoint than you see something like glucose. Things like albumin. Albumin is a very large molecule in comparison to the myoglobin, so that should also not be filtered. A very small percentage of that will be filtered because of the fact it's just too big to get through, right? So again, all goes to the size. Something that has to do with the negative charge on it. So lots of things can factor into this. Okay, so I mentioned with filtration, a substance can be freely filtered and then neither be reabsorbed or secreted. So basically, the concentration that gets filtered out is going to be the same concentration of what exits in the urine. So that can be very useful in some cases, especially when we're trying to determine what actually is the function of the kidney. And I've mentioned creatinine clearance before, right? Remember when I talked about that? That's basically going to be a surrogate for GFR, this glomerular filtration rate. And we use creatinine because whatever gets filtered at the glomerulus is basically what exits out in the urine. For the most part, it's pretty close. There's a little bit that gets reabsorbed, but for the most part, you're going to find that that one is a good estimation of that. Okay. Some things can be filtered very freely, but are also going to be partially reabsorbed. So again, you have a little bit of sodium and chloride that goes out in the urine, but for the most part, you absorb a lot of it. Okay. So again, in this case, there's going to be situation A and B, where situation A where it gets filtered, goes through, nothing reabsorbed in this case, nothing secreted. With part B here, you're going to find that, for instance, like sodium can be filtered. A lot of it's going to be reabsorbed, but then some of it can escape through into the urine potentially. Okay, so again, this is going to be with just filtration, whether or not it gets reabsorbed essentially. With substance C, you're going to find that the substance is going to be freely filtered, but then actually none of it gets excreted under normal circumstances because it gets reabsorbed so extensively. So for instance, with glucose, amino acids, you're going to find that even though we're filtering it, it's going to be absorbed very easily, it's going to be absorbed very extensively, and none of it is going to get out. Okay. Now again, we're going to find there's going to be a saturation point with a lot of these transporters to where if you overload the system, if you filter out too much, where's it going to end up eventually? In the urine, right? So that's why you find like diabetics who have their glucose out of control. You're gonna find they're gonna have a lot of glucose spilling out into the urine, or you can have like protein spilling out into the urine because of that. Because typically they get reabsorbed, but the kidneys are not functioning normally, or the load's too large. You can find that issue being filtered out.
So is this where the protonation of acids occurs? And why they're like retained and deposited in your
Yeah. So again, when you're looking at the nephrons, you're going to find the pH can be modified from what the actual normal serum pH is, because we mentioned like the urine pH is anywhere between like say 5, 5.5 up to like maybe 7, 7.5, somewhere around that. So it's a wider range than you see with the serum, normally being 7.35 to 7.45, pretty narrow when it comes to the serum. This is where you can have that effect occur, where basically you could have something that normally would be excreted out no problem, but if you change the protonation, maybe you increase its reabsorption. Right, so that's exactly what we're talking when we talk about aspirin, how we can modify the pH and make it so that less of it is reabsorbed and more of it just gets excreted out in the urine. Right, makes sense. Anyway, and they're going to find that in situation D here, the substance gets freely filtered. However, it's not absorbed, but you can actually have additional secretion into the renal tubule, and you're going to find that's where you can have things like organic acids go through specific transporters to where it gets filtered to a certain amount through the glomerulus, but the concentration coming out in the urine is even higher than what was filtered, and because of that, you're going to find that's due to secretion, active secretion of the substance. Okay, make sense? Again, the afferent arteriole is going to be entering the glomerulus. It's going to be heading in, and again, by modifying this, so what do you think would happen if I squeeze down on the afferent arteriole? What do you think that would do to the actual filtration of the kidney? It would decrease, yeah, because again, you're decreasing the amount of actual blood flow getting to the kidney. So again, that could be an issue. So if you imagine you have someone who has, squeezed down or constricted afferent arteriole, that's going to be able to decrease how well the filtration is. This will become important. We're talking about that specifically a little bit later on, but kind of keep these things in mind and kind of what can happen if I affect the efferent arteriole as well. But basically what's happening, once the afferent arteriole is bringing blood in to the system, you're going to find that through those fenestrations, those kind of leaky capillaries, you're going to find things like sodium, water, glucose, bicarb, chloride, potassium, urea, creatinine, calcium, all this gets filtered pretty freely for the most part. Okay, so again, this is the first step of the actual filtration that happens. Most of your waste products, certain drugs, certain hormones can all be filtered out here through the glomerulus, right? And then it heads into which part of the nephron first? So after the glomerulus, it goes into the proximal, that makes sense because proximal convoluted tubule, right? So the PCT is going to be the next stop we're going to be hitting here. And again, looking at the actual filtrations, you imagine these different substances, and notice glucose. Maybe you're filtering about 180 grams per day of glucose. Notice the amount that reabsorbed here is going to be basically 100%, right? So again, none of it should be excreted out into the urines under normal functioning kidneys in these cases here. On the other hand, you have something like sodium. Again, the amount of milliequivalents per day we're going to be filtering out. Notice how much of it gets reabsorbed. We absorb quite an extensive amount of that. It's maybe 99.4% of it. Only maybe 150 milliequivalents get excreted throughout the course of a day. Okay. Again, most of these things you're going to find get reabsorbed pretty extensively for the most part, unless they're considered like waste products. Things like urea, and maybe only 50% actually gets reabsorbed. The rest of it can be excreted out. You're going to find that there's for every person there's a certain minimum amount of urine they need to produce a day in order to get rid of some of these waste products, right? So imagine there's a certain if you're really dehydrated, there's still a certain amount of urine you have to produce in order to get rid of some of these waste products here. And then we mentioned creatinine is a very good surrogate for renal function that we use in some of our equations, like the Cockcroft-Gault equation. This is good because it gets filtered. Not very much of it gets, for the most part, it's just about the same amount that actually gets excreted here. No reabsorption occurs, and so this is why it's a good surrogate. Okay. There's actually another product that's going to be a little bit better, and we'll talk about it later on. But again, this is the best one we have. Easy lab values that we can use to try to measure this. Okay, so again, we mentioned things like proteins, especially large proteins, blood cells, and other things that are not filtered are going to be exiting through the efferent arteriole. So again, not everything that goes through gets filtered out here, especially not all the sodium, not all the water necessary, because you want to have some volume here to go through the efferent arterioles. Actually, here's the efferents, so it's leading out from here. So you're going to notice that when you have this occur, we're going to talk about both colloidal and hydrostatic pressures. Now, what is a hydrostatic pressure? What do you think this is? So hydro, thinking water. Good. So again, this is going to be the pressure that's actually filling up the vessel there. So for instance, if I had less water, the hydrostatic pressure would go down, right? So again, you're going to find this is what happens in like dehydration, right? You're going to have less hydrostatic pressure. We're going to see what effect that has on actual filtration here in a second. On the other hand, we have colloidal pressure. Anyone know what that is? Yeah, it's like the proteins and the other things that actually hold fluid into the vessel, right? So you're going to find that the colloidal pressure is going to be holding things in. The hydrostatic pressure is pushing things out, essentially, okay? And we're going to look at how that actually can affect GFR here in just a minute, okay? So just saying hydrostatic pushing out, and that's what's actually filling up the vessel. Colloidal pressure is what's holding things in, essentially. So looking at this, imagine you have your afferent arteriole. So again, the blood flow is going to be heading in this direction, heading out from here. You're going to find that there's going to be kind of a balance here between the glomerular hydrostatic pressure, which is forcing out, which is pushing out essentially, and then the glomerular colloidal osmotic pressure, which is holding things in. So you can kind of notice here, these are going to be kind of at odds with one another here. And then of course, there's going to be a little bit of pressure here in Bowman's capsule, which is going to be kind of pushing back against this, right? So you have to look kind of the net sort of pressures to see if any filtration actually occurs here, right? So in this case, you're going to have, say, 18 millimeters of mercury pressure pushing back. You're going to have 32 millimeters of mercury kind of acting as a negative in this case because it's holding water in. But the main thing is pushing out against that to actually have the filtration occur is this hydrostatic pressure, right? So notice this is a lot higher than either the colloidal pressure or the Bowman's capsule pressure. So if you were to actually look at this, there's a net filtration pressure of about 10 millimeters of mercury. So in this case, where is the filtrate going to go? Or the fluids is here in the actual glomerulus, because it's net positive pressure here, right? Because again, these two pressures are not canceling out totally. The hydrostatic pressure is going to be forcing this way, so you have a net positive in this direction, which is actually what causes the filtration to occur. Okay, so imagine what would happen if you had, say, the Bowman's capsule pressure was much higher, and say it was too high for the hydrostatic pressure here, and the glomerulus actually force across. What do you think would happen to that filtrate? It wouldn't go in the right direction, right? It'd be basically trying to force it back into the glomerulus, which is not where we want it to go, right? We want everything to be heading down in this direction so they can go through and eventually be excreted potentially, right? So again, these pressures are important because if I modify any of these, you can decrease the actual filtration pressure. And again, this goes back to that glomerular filtration rate, or GFR. Again, if I have less pressure here, you're going to find that GFR is going to go down, which is important because if that goes down, guess what? I'm not going to be filtering things appropriately. I'm not going to be able to excrete them appropriately, and this is where issues can come up here, okay? So kind of keep these in mind. We're going to talk about some differences you can cause here between the afferent and the efferent arterial effects that can have here. Okay, so typically when you're looking at filtration rates, typically GFR is going to be the volume of filtrate that gets produced in the kidneys each minute. So again, typically a normal value would be between 115 to 125 mLs per minute or so, and that usually equals out to be about 180 liters per day. So again, do you excrete 180 liters of fluid in your urine? I hope not, right? That would be pretty bad. You'd be like you'd be beef jerky at that point, or I guess human jerky. It's not good, right? You'd be very dehydrated. So typically, you're going to have a lot of reabsorption of that water, and that's what's important to occur there. Now, are there cases where you can have increased excretion of that volume? Absolutely. There are certain disease states, certain drugs that can do that. But under normal circumstances, you reabsorb a ton of that water because, again, we don't have 180 liters to really give in those cases there. And typically, you excrete about a liter per day in most instances. And then basically total blood volume filtered about every 40 minutes or so. So roughly you have all your blood kind of cycling through and getting filtered roughly 36 times per day or so, right? And again, that's good. That helps keep a normal balance. Again, now, do you need every one of those times, every 36 of those times to occur? Not necessarily, because I mentioned you have a dialysis patient who goes every Monday, Wednesday, Friday, from roughly for about 4 hours or so. They're kind of filtering all that blood through, and that's usually good enough for them, right, to kind of keep things somewhat balanced there. But anyway, but for normal individuals, 36 times a day is getting filtered through. That number is not really so specific to know. I'd more focus on kind of what a normal GFR is. It is good to know for things like 115, 125 mLs per minute is usually pretty average for most people, right? And again, if I ask you a question on a test, I'll put normal. If I put like a lab value like a GFR or something or creatinine, I will put like a normal value in there as well, just like I did on this past test. Okay. But you think, oh, that's easy. If I tell you what the normal is, you should be able to figure out the problem. Again, it's not always so easy, is it? You're trying to interpret lab values. That's where it gets sticky. Okay, so again, when looking at GFR, basically you can figure this out by looking at the volume, the urine volume per minute, multiplied by the concentration of the substance in the urine. So again, when you're looking at GFR, we're typically calculating it from a specific substance that we're going to be analyzing, both the level that's in the blood, in the plasma, and also the level that actually gets sent out in the urine, essentially, right? So again, the concentration of the substance in the urine versus the concentration of the substance in the plasma here, right? So again, notice the plasma concentration in the denominator. So again, if I were to have, say, a higher value in the plasma concentration in the denominator, what do you think that does to GFR? It would decrease, all right? So that shows that less of that substance is being filtered than otherwise normally would be, right? Or for instance, if I were to increase the urine concentrations, GFR would go up. I know my filtration rate is higher for that particular substance because I know that the urine concentrations are a lot higher than maybe say in the plasma, for instance, right? So again, by using these values, you can determine what GFR is. And again, normally we're going to use something like creatinine is probably the more common one we're going to use as a surrogate for this. Okay, so looking at reabsorption. Now, typically what you're going to find is that reabsorption is just that returning of that substances in the filtrate, getting it reabsorbed back into the systemic circulation, usually going through those pericapillary tubules that are there. So again, a lot of these pictures, when you're looking at different spots in the nephron itself, you're going to find that we're going to see, typically you're going to have the renal tubule here, right? So you're going to have the cells that are lining that wall, right? And then we're going to have basically the interstitial fluid and then the peritubular capillary. So typically when you have reabsorption, things are moving in this direction, right? So you're going to have things that get filtered from the glomerulus, passing through, and then they can be reabsorbed. Now, some of these things can just travel through by these paracellular pathways. So notice they're kind of going in between the cells, right? In some cases, you're going to find they're actually going through the cells themselves, okay? Some things may be taken up passively. A lot of things are going to be going through transporters, okay? And so some of this you can find can just be kind of passive diffusion where things are going from high concentrations to low concentrations, right? So for instance, if I filter out all the sodium out of the blood essentially, and a lot of it's here in the renal tubule, but less of it is going to be in the peritubular capillary, sodium's going to go in what direction? So higher concentrations here than here, it's going to flow towards the peritubular capillary, right? That would be a passive diffusion, right? So again, no energy is actually used in those cases. Other times you're going to find they actually have to use active transport. When we said active transport means what? Using ATP, right? So we need that energy. And again, the kidneys are typically very oxygen dependent because they require a lot of ATP to make a lot of these transporters actually work. So they require a ton of oxygen to function. Which is why if you have someone who has a decreased blood volume or they have hypotension or sepsis or something like that, that decreases the blood flow to the kidneys, you can have a lot of damage that occurs there because again, once they have to switch over to anaerobic metabolism, things don't go right for them for very long, right? So basically active transport, you're going to find that is also going to be very important to help kind of move things from the filtrate back into the peritubular capillaries, and then from here, where does it go? You remember it's going to go back through and dump out into the inferior vena cava and then back into the systemic circulation essentially, right? So again, all the stuff that whatever gets filtered and then it gets reabsorbed is going to go right back to the normal systemic blood flow, okay? So that's what you're going to find. So again, looking at this, say 180 liters of water gets filtered per day, but we're only excreting 1 liter. That shows that a lot of reabsorption is actually occurring here. And so again, this will typically increase. So imagine I drank a gallon of water. That would typically probably increase the amount of urine I'm outputting there. If I were to be dehydrated, the opposite would occur. I'd probably be trying to excrete less. I'd probably reabsorb more water because I want to maintain that intravascular volume to maintain my blood pressure, right? And so you can find the urine osmolality can actually range pretty dramatically. So imagine if I'm overhydrated, I have too much volume on board, what do you think it's going to do to urine osmolality? Decrease or increase it? So imagine if I have a ton of water and I go to the bathroom, is my urine really dark yellow color, or is it going to be, well, almost clear? Clear. When you think, well, clear, you think very low osmolality. There's not a lot of solute there, there's a lot of water. So typically if you're overhydrated, urine osmolality can be very low because I need to get rid of the extra fluid. On the flip side of that, imagine someone who is dehydrated, urine color is typically a little darker, a lot more concentrated. The osmolality is a lot higher in those cases. And so this can range pretty dramatically between 58 milliosmoles per liter up to 1200, right? Remember what the normal blood plasma normal osmolality is? Right around 300 or so, right? Around 300 milliosmoles per liter. Again, we want to keep that in a very narrow limit, but with the kidneys, we can modify that greatly between 50 to 1200 milliosmoles per liter. It's a huge amount. We can modify that. And again, this is all to help maintain fluid balance within the body, okay? And typically, you're going to find that there's a limit. We can only make things so concentrated because, again, at some point when the concentrations here on this side, the paratubular capillaries, are too high, that's going to do what to the flow from the filtrate? It's going to impede it basically, right? Because again, even though you may have some active transporters, even those can get overwhelmed, and so sometimes you actually have backflow of ions back into the urine. So again, that's why there's only a limit or a backflow of fluid in these cases to how concentrated we can get. Okay. Now, in some cases, you may find certain animals actually is kind of I find it being an interesting fact. But anyone ever heard of the kangaroo mice? They have some of the most concentrated urine in the world, and they actually live in the deserts. It's because their nephrons have so long they are able to concentrate it much more than humans can. So, for instance, we can get to a max of 1,200 milliosmoles per liter. They can go to 5,500 milliosmoles per liter. So they can concentrate the urine very much, meaning that they don't have to get rid of a lot of fluid, which is good when you live in the desert, right? So again, you guys aren't going to be vets, but BA, so I'll focus on humans from here on out. But I watch a lot of Planet Earth with my kids, so I get to learn little factoids like that, and then I Google stuff. But anywho, what this means, because there's a limit to how concentrated we can get the urine, and we know that we're kind of filtering, roughly that 180 liters per day, roughly is equivalent to getting rid of 500 mLs per day, right? This is considered a minimum obligatory loss in order to get rid of fluids, right? To get rid of fluids, to get rid of these waste products, because we can only concentrate the urine so much, right? So everyone's going to have at least some amount of urine you have to produce every single day. And again, looking at the amount of O2 the actual kidneys need, it makes sense when you're looking at all these different ATP-dependent transports we're going to have here, these active transports. Kidneys use about 2 times as much oxygen as the brain does, and it gets about 7 times the amount of blood flow. So again, you can see if you were to say diminish this, because again, if the body is at a state where you're say hypovolemic and you're hypotensive, I mentioned the 2 organs the body wants to perfuse is what? Brain and the heart. Kidneys can take a back seat to that, but again, they're very oxygen dependent, so that is only going to be good for so long because eventually too much anaerobic metabolism, you're going to find these cells are going to take a hit, and that's when you can have things like acute kidney injury that can occur there, right? So again, it's a common thing we see in a lot of ICU patients who are hypotensive. They develop acute kidney injury because we're depriving those kidneys of that oxygen. And again, you're going to find that the kidneys require some degree of basal oxygen consumption. That just means what? Say basal amount. It's not the spice in your spaghetti. It's kind of just the baseline amount you need, right? So again, the kidneys require a certain amount of oxygen, but that can fluctuate based on, for instance, how much sodium we're reabsorbing. So for instance, if I were to say eat a bunch of salt tablets or eat a big bag of potato chips or something, and that salt load goes up, I need to reabsorb some degree of that salt that requires ATP. So you can find that the actual oxygen consumption can go up pretty dramatically here. It's always going to require at least a certain baseline, but that can definitely increase as the need for filtration and reabsorption actually occurs. Okay. So again, you can imagine this looking at, say, sodium being filtered out through into the tubular lumen. Again, some of this may be passive flow, but in a lot of cases you find that you need things like ATP to utilize some of these transporters to actually make sure you get that sodium back into the paratubular capillaries. Okay. All right. And again, just some other cases we're looking at reabsorption that occurs here. So you can find that we can modify these pretty dramatically based on what the needs of the kidney are, the needs of the body. So for instance, when you're looking at, say, the tubular lumen, again, here's the interstitial fluid, and you're going to have the paratubular capillaries. Again, this is all based on pressures here. right? So again, you're going to find that, based on the colloidal pressure and then based on the hydrostatic pressures, you're going to find this can modify how much water flow we're going to have and then flow of certain electrolytes and other kind of products, as we're going to see here. So again, looking at, say, for instance, we're in the renal tubule, you're going to find that, remember, as the fluid left through the efferent arteriole, remember that the hydrostatic pressure is diminished, so we're losing fluid because it's being filtered. But what happened to the colloidal pressure? Typically increased because, again, you have a higher concentration of that stuff there. So now we're going to find that the colloidal pressure is higher. The hydrostatic pressure is going to be, I'm sorry, colloidal pressure is here indicated by pi, and you're going to have the hydrostatic pressure here. Normally, you're going to find there's kind of net cause of water just via osmosis to want to be reabsorbed here. So again, you're going to have kind of a net reabsorption pressure that occurs, which is good because, again, we don't want to pee out 180 liters a day, right? And again, imagine if you were to have, say, decreased reabsorption, if the pressures are such that you're going to find that you have that pushback from the intertubular, peritubular capillaries, and you can find that it can actually diminish absorption. You can actually have backflow of some of these ions and water and things like that. And again, that's what's going to limit how much of a concentration we have. So again, if the net pressure is kind of forcing back in this other direction, that's where you have that backflow occur. Okay, make sense? All right. So there's some cases where you also have things like secondary active transport. So this is the case where we're actually looking at absorption of glucose from the kidneys, right? So again, we see the glucose gets filtered very well through the glomerulus, but however, we should be excreting none of it in the urine under normal conditions, right? And so this can occur through what we call a secondary active transport. So in this instance here, imagine we have something called an SGLT co-transporter, right? Co-transporter just means moving two things at the same time in tandem. So for instance, this one works on glucose and sodium, okay? This one also, a different transporter works on sodium, say amino acids. And so what you can find is that here's an active pump. Notice what this pump is. Sodium potassium pump. It came back again. Yay. Everyone loves the sodium potassium pump, right? All right. So again, this is doing the same thing, right? Pumping sodium against the concentration gradient, pumping potassium against the concentration gradient. This is an active transport sort of phenomenon here. So basically what's happening, and you notice here's a GLUT transporter that's going to be working, basically it's just a facilitated transport, requires no energy. Okay, so you got all your transporters here. What's happening is the sodium potassium pump, this is kind of working, just chugging away just normally all the time, right? So again, sodium concentrations within the cell should do what? Should lower, right? So again, you should see lower sodium concentrations within the cell. What is this going to do to the high sodium concentrations out here? Because we're filtering it all from the plasma. So sodium is going to be higher on this side of things. So again, sodium is going to be high. Again, I apologize for my handwriting. I'm normally left-handed. Sodium is going to increase, and it's going to cause a net diffusion this way. And again, you're going to find that this is not going to be able to just filter across all by itself, but with these transporters, they're able to get across. So again, low sodium concentrations within the cell is going to drive sodium from the peritubular from these the tubular lumen through into the cell, right? So again, this SGLT protein here is going to be more active than it would be otherwise. So we call this a kind of a sink phenomena, where basically you're by causing a sink of sodium within the cell, it's going to be driving that transport more. It's going to make that transport more active, right? So sodium is going to want to come in more, and to do that, it's going to need these transporters here. So that means it's going to do what to glucose transport? Increase it or decrease it? Should go up, right? Because again, the sodium, it wants to re-equilibrate, right? It wants to maintain homeostasis. So by just diffusion through these facilitated transport, you're going to find the sodium influx is going to increase, which means glucose has to come along with it. So it's kind of it's kind of piggybacking along, all right? So it has to come along together. That's why it's a co-transporter. So by causing sodium to come in at a faster rate, glucose comes in at a faster rate, okay? And then glucose can go through these GLUT transporters. It's called secondary active transport, because even though this didn't require energy, where you're still utilizing the energy from this transporter to actually make the whole thing run. Make sense? Hopefully. See a lot of blank stares, so that's okay. So again, just know that the active transport causes a sink here within the cell. It's going to cause these transporters to become more active, which then can allow for these transporters to be more active, and then glucose gets reabsorbed. Again, none of this required energy, is only the secondary use of energy from the sodium potassium pump here. Okay. Same thing can happen with amino acids. So again, having that sodium sink is going to cause amino acids to be reabsorbed as well, because again, you don't typically want a lot of protein being spilled into the urine, most likely. Right. And what's actually kind of interesting is there is a new drug out in the market. It's a newer drug for diabetic patients that actually inhibits this SGLT transporter. So what do you think it does to the glucose that gets filtered in the urine? So it gets filtered, but now it can't be reabsorbed. So it means, where does it go? Out into the urine, right? So you just excrete all this really sugar kind of rich urine that normally you wouldn't have otherwise. Normally you would have reabsorbed it. By inhibiting that, you're just peeing it all out. And guess what? You lose all that glucose, lose all those calories potentially. That helps them get their glucose under control, helps them, actually they can lose some weight a little bit when they do that. But what do you think one of the downstream effects of having all that glucose there in the urine is going to be? Who likes to eat glucose? Bacteria, also fungus likes to eat bacteria. So one of the side effects they see from this drug, because the glucose concentration in the urine is so high, fungal UTIs are starting to develop. And again, fungal UTIs are not a common thing, right? So again, that's something like, okay, well, that's weird. Why would the patient have a fungal UTI? Well, a lot of it's because of all this extra glucose in the urine there, right? So again, sometimes you can modify these things to actually treat some certain diseases, but you may have kind of untoward consequences down the road. Yes, sir?
Did you say that SGLT requires or does not require ATP?
This does not require ATP.
Okay.
So again, this is a facilitated transport, but does not require energy. It's not active. The only active transport happening here is this ATP sodium potassium pump. Okay. But again, by utilizing this, you're still driving these passive pumps to work more quickly, to work more efficiently, essentially, right? Okay. Again, same thing can happen here with certain cases of excretion, where actually when you have the sodium potassium pump working here, you're still getting a sink of sodium within the cell, so the concentration are pretty low here. So this is actually going to be an anti-transporter, where actually sodium comes in at the loss of hydrogen ions. So again, if you imagine what this might do to the urine pH, like excreting those hydrogen ions, you'd acidify the urine, right? So again, that could be one way to actually help with the acid-base balance, is by actually excreting those extra hydrogen ions and maybe building up in the blood potentially, right? So again, that's one way that kidneys can help to kind of regulate blood pH essentially. Okay, but again, this is all secondary active transport. Now, can we transport these things kind of ad infinitum? No, you're going to find that you're going to have a saturation point for all of these. So, for instance, when you have, say, plasma glucose concentrations here, notice, what's a normal plasma glucose? Like 70 to 100, somewhere around that. So, however, if the plasma glucose were to go, say, 200, 300, 400, like when would you see this? Someone's like diabetic ketoacidosis, or someone has like some other like uncontrolled diabetics. I mean, they can get pretty high glucoses here. What you're going to find is there's going to be a transport maximum. There's going to be a point where you're going to have, and again, as you increase the glucose in the plasma, you're going to find that the amount of filtered glucose that is going to go up as well. But typically, even if you have an increase in filtered glucose, you should have an increase in reabsorption that occurs, right? Because again, you want to make sure that no glucose is spilling onto the urine. However, at a certain point, you're going to find that once you hit this transport maximum, notice how the excretion is very low for the most part, but up to that threshold, you're going to start to see the excretion goes up. So again, filtered load is always going to keep going up no matter what, because we all still filter out the same amount of glucose, but the amount of being excreted is going to start to go up pretty dramatically once you hit that saturation point, okay? So that's why, like diabetic patients, if they have uncontrolled glucoses, you're going to find that if you did a urine dipstick, you'd find that yes, it's positive for glucose, okay? Same thing can happen with like proteins. If you have if you kind of oversaturate those transports, same thing happens there. So so for instance, glucose maximum transport, say 375 milligrams per minute. If you get above that, that's when you're going to start to see excretion go up pretty dramatically at that point, right? Same thing for phosphate, amino acids, creatinine. Again, you're not going to memorize these numbers here, but just to give you an idea that everything has a limit to when it's being reabsorbed. Okay. So again, filtration, reabsorption, we talked about that. Again, excretion can also occur, but we'll talk about that in a minute. Okay, so we mentioned that after things get filtered through the glomerulus, they're going to be hitting into the proximal convoluted tubule. This is where the lion's share of reabsorption actually occurs here, okay? So roughly 50% of all reabsorption is going to happen within the proximal convoluted tubule. And again, looking at this picture, you can see the large number of substances are going to be reabsorbed here. So like sodium, chloride, potassium, calcium, bicarb, amino acids and glucose, urea, all these things get reabsorbed from the proximal convoluted tubule. So again, a lot of energy being utilized here, again, by using that secondary active transport, okay? Again, that's why they have a lot of mitochondria here, right? Again, looking at that brush border to generate that ATP to drive those active pumps. So roughly about 65% of the sodium gets actively transported out of the filtrate by that sodium potassium pump, as we know. About 65% of the water reabsorption occurs here as well. And again, that's important because, again, wherever salt goes, water wants to follow as well. So this is going to be one of the big things you're going to notice here, that as salt gets reabsorbed, water wants to follow it along, okay? So also a lot of bicarb that gets filtered out also gets reabsorbed here in the proximal convoluted tubule. And actually, when we talk about diuretics in Pharm 1, you're going to find that their bicarb gets reabsorbed via carbonic anhydrase activity. Remember what carbonic anhydrase does? Converts bicarb into CO2 and water eventually, right? So again, it's from the carbonic acid that can be converted over into CO2 and water. Again, CO2 and water can be reabsorbed a lot easier than the actual bicarb itself, because remember, bicarb has a negative charge on it. Does that like to cross biologic membranes super easily? Can't do that, right? So that's why carbonic anhydrase is going to be important there. So we'll talk about inhibitors of that and actually how that can work as a diuretic. But anyway, so a lot of bicarb gets reabsorbed here. And again, if that was impaired, what do you think would happen to the patient? Say I was spilling out bicarb in the urine. Patient would become acidotic, right? So again, you see a decreased pH, and that would be more of a metabolic cause in those cases, right? So metabolic acidosis due to spilling a bicarb in the urine, okay? All of the amino acids and glucose should be reabsorbed here in the proximal convoluted tubule, and about 50% of urea. Urea is going to be really important for helping us to maintain the dilution of the urine, as we'll see, and so we'll look at how urea gets cycled through here a little bit later on, but about half of urea gets reabsorbed. And again, these pictures are kind of nice because they'll show you kind of what absorption is actually occurring here. Also, if there's any secretion of substances, that will also be shown as well. So again, looking at the proximal convoluted tubule, again, right here, kind of very early stages here, you're going to have a lot of sodium, chloride, bicarb, water, all being reabsorbed here. About 65% of those substances, amino acids and glucose, 100% being reabsorbed there. Very important reabsorption point. Yeah, some secretions here of hydrogen ions, some organic acids and bases, and typically what you find is that this is going to be isoosmotic to the actual what gets filtered from the plasma. So we're going to look at the osmolarity of the filtrate here in just a few minutes, but just know that because again, normal plasma osmolarity is what I mentioned. 300, right? So again, because water and salt are being reabsorbed at a pretty equivalent rate here in the proximal convoluted tubule, you're going to find that it's going to still be isoosmotic. So it's still going to be at roughly 300, even here in the proximal convoluted tubule. This is going to be important. We're talking about how do we concentrate things a little bit later on. So kind of keep that in the back of your mind. Things are still isoosmotic here. Okay. And you can kind of see, looking at going through the proximal tubule length, you can see how these concentration of different substances are going to be changing over time, right? So for instance, looking at glucose and amino acids, as you get through the proximal convoluted tubule, it should be approaching 0, right? So again, you should be reabsorbing all of that. Certain things may be more concentrated. So for instance, like creatinine may be a little bit more concentrated just due to decreased water volume there, right? So it gets a little bit more concentrated, but notice that salt, the osmolarity concentration should be staying roughly the same. Okay, because again, they're going to be reabsorbed roughly the same amount with water. Okay, so I mentioned active transport of sodium is going to attract chloride, so that's why those go together, right? And then again, where salt and chloride are going to go, water wants to follow along with it, right? And again, you can also find that by having the sodium being pumped out, you're going to find that's by causing that kind of net positive there, that's what draws the chloride along. So again, because they want to make sure that the charge is actually going to be balanced out there as well. So again, that's what helps to draw that along. Again, water just going via osmosis, passive diffusion. There's no active transporters there in those cases. But because those paratubular capillaries are going to have a higher sodium concentration, that's what draws the water along with it. Again, looking at this, the actual filtrate gets reduced by roughly 65%. So you only have about a third of the original volume as what you actually filtered out here in the glomerulus, but it's still going to be the same tonicity as you would find as what the actual plasma was here. Okay, because again, a lot of that water and salt get reabsorbed in equal amounts essentially. Okay. So again, looking at reabsorption here, salt reabsorption is going to be causing a negative, a luminal negative potential. That's what's going to drive the chloride to be absorbed along with the sodium. And then the water reabsorption is going to occur via mostly just passive diffusion, usually due to osmosis there. And then that's why you're going to see a little bit of increase in urea concentration occur because the volume has actually gone down by about 2/3 or so. Okay. Okay, so looking at some secretion that occurs within the proximal convoluted tubule, again, some hydrogen ions are going to be coming out. Again, we saw earlier how sodium and hydrogen ions have those kind of counter transporters where that occurs. Certain toxins and drugs can also be secreted through the proximal convoluted tubule here. And so again, there's going to be specific transporters that are responsible for all of that. So for instance, there's like an organic ion transporter of the oats. If you ever see oats, that's referring to those organic ion transporters in the kidneys. And everyone's familiar with the drug penicillin, right? What do you use it for? Yeah, bacterial infections. And so there's another drug called probenecid. It's actually kind of interesting. This is actually utilizing a drug interaction for our own benefit, essentially. Penicillin was originally discovered. We didn't have a good way to make it because penicillin comes from where? comes from a mold, right? So again, we didn't have a way to synthetically make it, so the supply we had was pretty short for the most part. So we wanted to make sure that whatever we put into the patient stuck around for as long as possible to kill the bacteria. However, we knew that it got secreted into the proximal convoluted tubule, and then once you pee it out, it's not really active anymore. So what they used to do back in the day, before we had easy ways to make penicillin, we give it with a drug called probenecid that actually inhibited the secretion of penicillin into the renal tubules. By inhibiting that, you kept the penicillin levels up higher and actually were able to stick it around for longer to actually treat the bacterial infection, right? So again, you can modify this. This is where a lot of drug interactions can occur here as well. So just, again, I'm not going to ask you that specific example, but just know this is ways where we can actually use drug interactions to our favor in some cases. Okay, moving down into the loop of Henle, you're going to find, again, there's going to be a descending portion, and we're going to have the ascending portion as well. On the ascending portion, there's going to be a thin part and a thick part. What you're going to find is that primarily what we're going to be focusing on is going to be the functions of the thin descending portion and the function of the thick ascending portion here, okay? So what we're going to find is that typically in the thin descending portion, you're going to have a lot of reabsorption of water. It's going to be a very easy way to absorb water here, very free flow of water that occurs here. On the other side, on the thick ascending loop here, you're going to find that this is going to be water impermeable. Okay, so no water is going to be flowing out in this case. However, we're going to have some active transporters that are going to be causing reabsorption of things like sodium, chloride, and potassium. Those are some of the big ones. We'll also see some calcium, some bicarb, magnesium, but these three, sodium, chloride, and potassium, are the big ones that get reabsorbed here in the thick ascending portion of the loop of Henle. Okay, because this is what actually allows us to help with concentrating of the urine. Okay, so we mentioned that even though 65% of the salt in the water get reabsorbed from the proximal convoluted tubule, it still retains basically the same tonicity as you see with the actual plasma. So again, if you're looking at tonicity as we go through, you're going to find that it's roughly 300 in the plasma. What comes out is roughly 300, and it will stay that way until it gets down to the loop of Henle. Okay. Once it gets down here, where again this is going to be very water permeable, you're going to find that water gets reabsorbed because, again, looking at the actual colloidal pressure within the peritubular capillaries has actually gone up due to the fact that we have less volume there. It's caused water to be passively reabsorbed. Okay, so water gets reabsorbed. What do you notice about the tonicity as you go down? Less water makes the stuff that's in the renal tubules more concentrated, right? So you're going to notice that the tonicity is actually going up pretty dramatically. And then when you get back up here, you're going to notice that this is going to be water impermeable in the thick ascending portion. And then we're going to have some active transporters that are actually going to be shuttling sodium and chloride and potassium out of here. And then what does that do to the tonicity, do you notice? It's going to drop it down because, again, we're losing a lot of that solute. So it's actually going to make it very dilute, right? So again, maybe only get up to like maybe 100 milliosms per liter here, okay? So just note that it's going to get more and more concentrated as you get down. Again, this is projecting down into the medulla. So the farther down you project down, the more concentrated you're going to be able to get that urine right here at this portion here. And as you go back up, it should be basically hypotonic in comparison to what was actually filtered out in the first place. Okay. And again, based on this, is going to allow us to eventually, when we get to the collecting duct and talk about that, it allows us to actually get our final concentration of the urine, whether it's very dilute or whether it's very concentrated. Everyone with me so far? Okay. So again, in the thick segment, you're going to find additional sodium, chloride, potassium. All that is going to get reabsorbed in the ascending loop of Henle. Again, these are going to be not permeable to water. So again, the only changes in osmolarity that happens here is based on the solute that gets shuttled out of the cell itself, out of the renal tubule, and this is why it's going to get more dilute as projects into the distal convoluted tubule here in a second. Okay. Okay, so looking at the loop of Henle, we can see here. This is going to be the thick ascending portion of the loop of Henle. This is where you're going to find these active transporters that are shuttling sodium, chloride, and potassium. Notice here's 2 chlorides because, again, this balances things out because, again, you have 1 sodium is positive and potassium is positive, so you have 2 chlorides there. And that's going to be shuttling things in. And then you have the sodium-potassium pump that's going to be helping to get the sodium reabsorbed in those peritubular capillaries. Okay. Again, you're going to find that as potassium levels are going to be increased here, this is going to have some passive diffusion kind of in both directions, essentially. So you'll lose a little bit of potassium here, but the big thing is that sodium reabsorption. That's what's going to kind of drop the osmolarity in the thick ascending loop here. This is an important part because this is actually where you're going to find where your loop diuretics work. Anyone ever heard of Lasix before? Furosemide, it's a very common loop diuretic that we use for a lot of patients. It helps to get rid of a lot of fluid. If you give it to a patient, you'll pee like crazy. Because basically by inhibiting this, what do you think it does to the osmolarity within the renal tubule? Or to shut this pump down, all of it's going to stay out here in the renal tubule, and guess what? a lot more solute in there, and then eventually when it gets in the collecting duct, it's going to have a lot of water that goes along with it. So that's why you end up having a lot of fluid loss when you have someone who takes like a Lasix or furosemide or something. That'll become more important when we talk about things like CHF, when we're trying to talk about like fluid balance. Yes, ma'am.
Is this considered secondary active transport?
This is, you're going to find this does require some energy here, so I wouldn't call this secondary active transport, but certainly like this pump here, where it's going to be secreting some hydrogen ions, would be. But yeah, this is definitely going to be one that does require some energy, as you'll see. But anywho, and again, I'm not going to ask you specifically like which pumps are active versus inactive, because I mean that would be kind of in the name. If I said like sodium potassium ATPase pump, you should probably be able to parse out that has ATP used, or it should be active transport. But I mean, that's like, specifically like, say in the thick ascending loop, what is being reabsorbed here? What is actually occurring at each of these different points in the nephron? Or if I were to modify this, if I were to inhibit, say, this pump, what happens to these downstream effects? Those are the kind of things we're going to be kind of focusing on, and we'll show some example questions on the review before the test, right? So anyway, and so we're going to talk about this, how this concentrating effect occurs here. Oops, sorry, just a minute here. But basically, again, descending loop, you're going to have water reabsorption. Ascending loop in the thick portions, we're going to have salt reabsorption. The biggest effects you're going to be finding there. And again, as you get farther down into the nephron, the further it projects down, you're going to get more and more concentrated filtrate here. Okay. And so this is called the countercurrent multiplier. Sounds fancy, but basically this is our means of getting such a concentrated filtrate down at the very bottom here of the loop of Henle. So essentially what's happening is, imagine the plasma that gets filtered. It's coming out, we mentioned, has an osmolarity of roughly 300 milliosmoles per liter, right? Okay, so imagine that was going all the way through the kidneys. So imagine you had, say, a brand new kidney, you're just starting it up, just priming the pump with the urine. It's all 300 osmolarity filtrate coming out through here, okay? So basically coming through, you're going to notice here, let's say we start up these pumps, they're going to be causing reabsorption of sodium chloride and potassium, okay? So you're going to notice here the osmolarity within the thick ascending portion is going to decrease, because again, we're reabsorbing all that solute. You notice here in this interstitial fluid, it's going to be going up, right? Because we're kind of increasing the salt concentrations right there, okay? So because this portion is going to be water permissive, right, it's going to be able to allow water to flow, you're going to find there's going to be an equilibration that actually happens here, to where basically water is going to want to flow out, and it's going to basically re-equilibrate to where, okay, say we have roughly 400 milliosmoles per liter, right? And again, you're going to find that as you project further down, you're going to find that you start to see this this gradient that actually will form here, where you have a little bit, say, normal osmolarity here, but it gets more concentrated as you flow down further into the medulla, okay? So this whole cycle will happen again. We're going to be pumping more sodium out into the interstitium here. You're going to have more water flow in this direction, as we'll see right here. And so you notice this countercurrent multiplier occurs, where basically you get very concentrated filtrate at the very bottom. However, things are kind of normal here on the thin descending loop, and it's very dilute here up in the thick ascending loop. Make sense? And again, if you imagine those kangaroo rats, imagine they would have very deep kind of medullary projecting nephrons there. They would be able to get down to, like, say, 5,500 milliosmoles per liter in those cases, right? Because again, this is the max concentration we're going to be able to attain within the kidneys based on this countercurrent multiplier. Okay, how are we so far? All right. So then moving on from there, you're going to be heading into the distal convoluted tubule. And so basically you're going to find this is kind of divvied up into two portions here. We're going to have the proximal form here, where basically this is where we're going to have our macula densa. We're going to have our juxtaglomerular complex. This is where it's going to be really important for helping to regulate renin release due to things like salt concentration and blood volume, as we're going to see here, right? So again, you're going to notice here, this is where it's going to be approximated with those afferent and efferent arterioles. This macula densa here, and we'll talk more about what that does in a few seconds. Basically, this is going to help to provide feedback control for GFR and blood flow. So for instance, if I said I had low blood volume, and say I wasn't filtering very much of the glomerulus, blood volume would be decreased here. And so that's going to signal the kidneys that, hey, we need to get blood pressure up. We need to get more blood coming into the kidneys. Let's go ahead and activate the renin-angiotensin system. And this is basically what's going to be happening here, right? These juxtaglomerular cells in the macula densa. But anyway, in the early portions of the distal convoluted tubule, the main thing you're going to find is a lot of salt and chloride reabsorption. And again, if you ever heard of like hydrochlorothiazide or diuryl or HCTZ, anything like that, this is where your actual thiazide diuretics, where they actually will inhibit this pump to cause diuresis to occur there. But anyway, by having this pump active here, you're going to again cause sodium to be flowing in. This would be another form of secondary active transport, you'll see, because again, the sodium sink is going to be happening there. And again, that's going to cause sodium and chloride reabsorption. Okay. You're going to have the next portion, which is basically called the diluting segment. So this kind of feeds into the collecting duct. So we'll see here. So again, the functions here, the kind of the secondary portion of the distal convoluted tubule is pretty similar to the collecting duct, as we'll see. Here you're going to find it's going to be pretty impermeable to water and urea. So again, it's going to be kind of dilute here. However, we can reabsorb sodium, potassium, and chloride. So this means the water that's here is kind of here, but the solute can be reabsorbed. It's going to do what with the concentration? The osmolarity is going to go down because again, that water stays there, but the solute's leaving. That's why it's called the diluting segment, basically, right? So again, you're able to get very dilute filtrate right here at this portion of the distal convoluted tubule. Okay, we're going to find there's two primary cells here. There's going to be primary cells and then these intercalated cells, as we'll see. You can kind of see how they're working together. So again, here they have these intercalated cells, and here's the principal cells, and they're going to be working together, and they have different functions, as we'll see in the next slide here. Okay, so imagine you're looking at, again, we're talking about the diluting segment here of the distal convoluted tubule. Again, no water is really being absorbed at this point. However, we are seeing solute changing around. We're having reabsorption of things like salt and potassium. So basically, we're going to have two types of intercalated cells, type A and type B, and then we're going to have our principal cells are going to be located here. And again, note this is where we're going to have things like aldosterone being playing a role here. We mentioned aldosterone does what to us in the kidneys? Reabsorbs salt and water, but then also will help to stimulate release of potassium. And this kind of makes sense here. So again, if you had aldosterone working here to make these pumps more active, you're going to find you're reabsorbing more salt. Again, it causes that salt sink. So again, they have that decreased concentration here, which causes just natural passive flow of sodium into the cell. And again, you're going to find that potassium is going to be sacrificed because of that. Okay, so again, more salt reabsorption, but more potassium being excreted into the kidneys. Again, that's going to be through aldosterone effect here. Now, the intercalated cells are going to be more important for helping to regulate the pH of the urine overall. So, for instance, you're going to find that these type A intercalated cells, you're going to have things like secretion of hydrogen ions here. And the type B intercalated cells, you're going to want to have secretion of bicarb. Okay, so for instance, if I were to have, say, very acidic urine, that could be caused by the type A intercalated cell because they're secreting hydrogen ions here, versus if I were to have, say, more basic urine, more alkalotic urine, be due to the type B intercalated cells here secreting bicarb. Okay, so again, just know those are kind of the two primary functions of those intercalated cells. One to make it more acidic, type A, type B to make it more basic, essentially. Okay, again, this helps to regulate balance with the body as well. And if the body's too alkalotic, what is the body going to want to get rid of? Bicarb, right? Again, if the body's too acidic, it's going to want to get rid of hydrogen ions, and that's how these cells can be utilized here, utilizing the distal convoluted tubule, the diluting segment, in order to regulate that pH balance. Okay. Okay, next up we're going to go into the medullary collecting duct here. Again, this is where antidiuretic hormone is going to be playing a big role, right? So again, looking at the distal convoluted tubule, the secondary portion there is where we're going to see aldosterone being a big player. Here's where we see actual antidiuretic hormone. Again, the big thing antidiuretic hormone does is once it interacts with these receptors, it's going to cause these aquaporin channels to be put onto the cell surface, and aquaporin is going to allow for reabsorption of water, right? So again, it's only going to allow for water to flow through, essentially, and then it's going to be able to dilute or concentrate the urine, do you think? It'll concentrate the urine because, again, we're reabsorbing that water. Because, again, usually when do we secrete ADH? When our plasma osmolality is too high anyway, right? We want to dilute that out by reabsorbing water. So you can see how these are all kind of playing a role to one another. Again, usually you're going to find that the H2O permeability is going to be mainly dictated by ADH levels, right? So again, normally it's impermeable to water. However, if ADH is interacting with these receptors, you're going to find this is actually going to cause the aquaporin channels to be expressed and allow for water to be reabsorbed. Okay. Again, kind of going back to when we were talking about secondary messenger systems, notice here it's using cyclic AMP to activate these protein kinases, right? But again, the main thing I want you to know is AVP, or arginine vasopressin, right? Vasopressin, antidiuretic hormone, all names are the same thing. Are going to cause aquaporin channels to be expressed here at the cell surface. All right. Looking at calcium specifically, because again, calcium is important. If you have too much calcium being excreted out through the renal tubules, what do you think can happen? All the calcium starts to precipitate out into stones potentially. You can develop kidney stones maybe. Yep. Okay. So calcium is important, right? Because we need to make sure we can regulate calcium very well. People have a lot of calcium being excreted in the urine, which again, here in Florida, do we have a lot of calcium in our water, or tap water? We do actually, yeah. So a lot of people who move from out of Florida here sometimes complain of kidney stones due to the fact they have a lot more calcium in their water than they're kind of used to. But anyway, again, calcium regulation is really important because if we lose a lot of calcium, what can happen? What happens to your bones if you don't have enough calcium? Osteoporosis, right? So again, we like to maintain our calcium levels in a very strict sort of manner. So we're going to find that reabsorption occurs in several places within the kidney. So again, like the proximal convoluted tubule, ascending loop of Henle, distal convoluted tubule, collecting duct, all that. The main hormone is going to be affecting that is going to be what? Parathyroid hormone, right? Because again, parathyroid hormone is going to be secreted as a result of what? So low calcium levels is going to stimulate parathyroid hormone, right? And again, parathyroid hormone does what to the bones? Stimulates the osteoclast to start to break down bone and try to release calcium, right? It's going to do what to the GI tract? Increase calcium reabsorption, and it also does the same thing in the kidneys, basically, where it increases calcium reabsorption if your calcium levels are too low. So again, remember how parathyroid hormone is going to be responsible for that. Again, it's going to also stimulate vitamin D activation. Vitamin D also is going to help with reabsorbing calcium or absorbing calcium from the GI tract and also from the kidneys. This is also going to be playing a role here as well, right? But again, we said patients like kidney disease, what happens to their vitamin D levels? They're going to be decreased. They can't form the active form of it in the first place. So again, you find patients who have chronic kidney disease or chronically poor functioning kidneys typically are going to have a lot of issues with calcium homeostasis. They're also going to have issues with phosphate. You can see a lot of issues that develop from that. We'll talk about that in other courses. But just know calcium regulation is mainly going to be affected by PTH. Usually PTH is going to increase the amount of calcium being reabsorbed from the kidneys. Okay. And again, just looking at these cases of where electrolytes and different substances are going to be reabsorbed here. Notice things like glucose and amino acids, again, all in the proximal convoluted tubule, being reabsorbed very directly. A lot of things like, your bicarb, other things like that are going to be reabsorbed pretty heavily here in the proximal convoluted tubule. And again, later on, this is where we can control kind of how dilute or concentrated urine is going to be with like the loop of Henle, distal tubule, and the collecting duct. Okay, let's talk about urine concentration a little bit later. Okay. All right, so I'm out of time for right now. Any questions before I let you guys go to lunch? All right, if not, we will carry on next time.